Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series Webinar. This evening, we are going to be talking about the latest approved indication for COSENTYX. Our moderator this evening is Dr. Leon Kircik, who is the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences. Our speaker this evening is Dr. Jennifer Hsiao, who is associate clinical professor of dermatology and director of the Hidradenitis Suppurativa Specialty Clinic in the Keck School of Medicine, University of Southern California, Board of Directors, HS Foundation. We'd like to thank our supporter, Novartis, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in, and I'm going to take over the mouse and send it back to us. We'd greatly appreciate it. Within 1 to 2 days of the webinar, a certificate of attendance will also be emailed to you. So if you have any questions, please submit your questions using the question chat pane on the right-hand side of your screen. And I put a note there so that you know exactly where to put your questions. And without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone, and welcome. And thank you for joining us for another series of International Dermatology Education Foundation Educational Series. So tonight, we are very lucky to have Dr. Jennifer Hsiao, who's going to tell us about hidradenitis suppurativa for the new indication for COSENTYX. However, before we start, I want to tell you a little bit about International Dermatology Education Foundation, which is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Since the COVID pandemic, we've been started our virtual webinars, and virtually we have been all over the world. Next slide, please. We have been all over the world, including North America, South America, Canada, Southeast Asia, as well as Europe. Here are a couple of our previous programs that you can see, our invitations with all our speakers. And tonight, I'm very happy to present Dr. Jennifer Hsiao, who is Associate Clinical Professor of Dermatology and Director of Hidradenitis Suppurativa Specialty Clinic at University of Southern California. And she's going to talk about the latest approved indication for COSENTYX. Take it over, Jennifer. Thank you for joining us tonight.
Thank you so much for having me. I am going to resume control of the mouse. So let's click. There we go. So good evening, everyone, and thank you so much for being here. I'm so excited to be able to chat with you all about COSENTYX for HS. It's the first and only FDA-approved IL-17A antagonist for HS. So just to walk through what we're going to be talking about today, we'll start with the burden of HS on patients. We'll talk about the heritage of COSENTYX across various indications that it's been approved and used for, how COSENTYX can help your patients with HS, discuss the safety profile of HS, safety profile of COSENTYX in HS, and also how you can get your patients started. So to just set the stage regarding this topic of hidradenitis suppurativa or HS, it's a condition that has been sorely understudied. So despite the fact that it's a lot more common than once thought, we think that at least 1 in 100 people worldwide may actually be affected by HS. Many patients are underdiagnosed or misdiagnosed. In fact, On average, patients wait about 10 years before they have a diagnosis of HS. And so they're just walking around with a decade with these really painful lesions, not knowing what they have, and therefore not getting appropriate treatment. So undertreatment is also rampant. And so one of the key things I'm hoping you'll take away from this presentation also is how important it is for us to do early diagnosis and early management of these patients with appropriate therapies. So HS is a chronic systemic inflammatory skin condition characterized by recurrent painful nodules, abscesses, and also tunnels in the skin. It tends to happen in the private areas like armpits, groin, buttock area, under the breast, but can also happen in other areas of the body, like behind the ears. I've seen it on the trunk, sometimes even arms or legs. So just because it's not in the classic areas doesn't mean it's not HS, but the fact that so much of it is like armpit, groin, and buttock makes it really difficult for patients to raise their hands or sit down. Even walking, lying down can be painful. So very debilitating, and that's why it's so important for us to have medications that can help ease some of their suffering. So with disease progression, patients can have irreversible skin damage, scarring, and pain. So with those tunnels, we're already seeing irreversible skin damage. Patients also can have extensive scarring to the point where there's contractures. Pain is the #1 symptom of patients with HS, and almost 100% of patients will report pain. Especially with flares, when the disease flares, the pain is oftentimes so great that they just can't get out of bed. So starting a biologic treatment prior to development of multiple irreversible tunnels and scarring is thought to improve treatment outcomes, really going back to that message of finding these patients early, diagnosing them with the correct diagnosis, and starting appropriate treatment early. So we're not seeing patients in our clinic who have 20 tunnels all stuck together, coalescing, and you know that you're going to have to now do extensive surgery in addition to medical therapy. It'd be great if we can intervene early with medical treatments so we can reduce the amount of surgeries and suffering that patients have. So we're now going to talk about how we can help our biologic-ready patients achieve meaningful relief with COSENTYX for adults with moderate to severe HS. So starting with some background on COSENTYX, I'm sure a lot of us on the call tonight are familiar with using COSENTYX because it's been around for a long time. There have been 17 plus years of clinical trial experience, over 9 years on the market, over 4 million prescriptions have been written in the US, and there's also patient support programs that have helped patients access this medication. So the first indication was back in 2015. The FDA approved COSENTYX for moderate to severe plaque psoriasis in adult patients who are candidates for systemic therapy or phototherapy. This was followed by various other indications, including for active psoriatic arthritis, for active ankylosing spondylitis, non-radiographic axial spondyloarthritis, and then really importantly, opening up to our pediatric patients in 2021, moderate to severe plaque psoriasis in pediatric patients, enthesitis-related arthritis in pediatric patients, and all the way down to the age of 2 for juvenile psoriatic arthritis. And I think that also helps speak to the safety profile of COSENTYX when we're counseling patients about it. The fact that it has an indication down to 2 years of age is also very reassuring for patients to hear. So COSENTYX is the first and only FDA-approved IL-17A antagonist for adults with moderate to severe HS. It was approved on Halloween, so October 31st, 2023. So there were various very excited people in my household, including my 2 young children and myself, because I knew that now we had another agent finally for our patients who are suffering from this terrible condition. Let's talk about how and why COSENTYX is thought to impact HS pathophysiology. I'll start by saying HS pathophysiology is still under investigation. We know for sure there's aspects of immune dysregulation with the elevated cytokines that we're seeing, but also there may be hormonal factors, metabolic factors, genetic and epigenetic factors. So it's still being worked out, but we are seeing increased levels of interleukin 17A present in lesional and perilesional HS skin. Let's take a closer look. So when we see signs of HS on the skin, what might be going on underneath the skin surface? So the primary event in HS is thought to be follicular occlusion, which then results in follicular hyperkeratosis resulting in occlusion, which can contribute to the inflammatory responses. When the dilated follicle ruptures, that further activates immune cells of the skin. With this happening repeatedly, what we'll see on the skin surface are inflammatory nodules, deep abscesses, and with repeated, nodules, abscesses, we see formation of tunnels and also fibrotic scarring. And so there's a photo there of what repeated activity can look like with formation of this tunnel under the skin. COSENTYX binds to IL-17A and inhibits its interaction with the IL-17 receptor. So here's a photo description, basically a graphic, showing COSENTYX, the pink antibody there, binding IL-17A, inhibiting it from binding its IL-17A receptor to help reduce the downstream signaling that leads to signs and symptoms of HS, like those inflammatory nodules and abscesses. Let's talk now about the two phase 3 trials, the pivotal phase 3 trials that helped get COSENTYX get its FDA indication. They were the Sunshine and Sunrise trials. So these SUNNY trials were phase 3 randomized double-blind multi-center studies assessing the primary endpoint at 16 weeks and then also extending out to up to 1 year efficacy and safety of COSENTYX in adult patients with moderate to severe HS. It was conducted from January 2019 through July 2022 across 219 sites worldwide, so you can see the map there. So over 1,000 patients were enrolled in these two trials. What were the key inclusion criteria? So patients had to be at least 18 years old with moderate to severe HS defined as 5 or more inflammatory lesions, so abscesses or inflammatory nodules. Those lesions had to affect 2 or more distinct anatomic areas. So for example, someone could have had the right armpit and left armpit involved, or the right armpit and their buttock, for example, that would have counted. And they also had to have had a diagnosis of HS at least 1 year prior to the baseline visit. Patients were allowed to be on stable treatment with selected antibiotics, for example, tetracycline, and previous treatment with a TNF inhibitor was allowed. Patients were excluded if they had a fistula count of 20 or more, any active skin disease or condition other than HS that may interfere with the ability to assess HS, pregnant or lactating women, if they had active ongoing inflammatory disease. So for example, if they had active IBD, they were excluded, but patients with a history of quiescent IBD could be enrolled based on the investigator discretion, and previous exposure to any biologic directly targeting IL-17A or F or the IL-17 receptor. If they had previous exposure to that, they were not allowed in the study. So let's take a look at the study design. You can see here that the primary endpoint was at week 16. It was HiSCR 50. What is HiSCR 50? It's the hidradenitis suppurativa clinical response score. What it means is that patients had to have had a 50% or greater decrease in their abscess and inflammatory nodule count compared to baseline, with no increase in baseline number of abscess or draining tunnels. There were also secondary endpoints that were measured at week 16. This included the abscess and inflammatory nodule count, proportion of patients with HS flares, and also clinical response in HS-related skin pain. So achievement of the NRS 30, basically patients had to have a 30% or greater reduction in their global pain score, including a reduction of at least 2 points at week 16. So here you can see patients, they were basically randomized to be either in the COSENTYX 300 milligram every 2-week group, 300 milligram every 4-week group, or placebo. The loading phase was 5 weekly injections at first, followed by their maintenance dosing. So after that primary endpoint analysis at week 16, what happened next? Patients were actually studied all the way out through week 52, and that's why we have week 52 data already. And what we can see here is that placebo patients at week 16 were then randomized into either getting COSENTYX every 2 weeks or every 4 weeks. The patients that were already in their Q2 or Q4 week study drug arm from period A in the first initial study period, they basically stayed in their respective study arms out through week 52. And then at week 52, what were the endpoints that were explored? Some exploratory endpoints included HiSCR 50, and then also higher numbers for success, high score 75, 90, and 100. By high score 100, we're saying that there's a 100% decrease in abscess and inflammatory nodule count from baseline. So basically, there's no more abscesses or inflammatory nodules, which is, patients are definitely happy by then. And then there's also AN50, flares, the pain score, and then also the Dermatology Life Quality Index score that was assessed at year 1. What did the demographics look like between the different study arms? So we look at Sunshine and Sunrise. They're also broken up into their COSENTYX every 4, every 2 weeks, and then also placebo arms. You can see in general, the demographics were pretty balanced across the groups. In general, there was a little bit of a skewing towards more females in the study. Over half of patients weighed more than 90 kilograms, and the majority of patients throughout all the study arms and in the trial itself were Caucasian. Most patients were baseline Hurley stage 2 or 3. There were some Hurley stage 1 patients that were enrolled, and that's because they met the criteria for moderate to severe disease in that they had more than 5 or more inflammatory nodules or abscesses across 2 or more anatomic regions. And I think that goes to show that Hurley stage isn't necessarily the best way to determine how severe someone's disease activity is, right? You could not have a sinus tract, but still be considered to have moderate to severe disease. About 40% of patients had had previous surgery for HS. And then patients also, there was a group with previous exposure to anti-TNF alpha therapy, and the majority of patients had previous exposure to systemic antibiotics like we would expect. And just to call out here that it was about 24% of Sunny trial participants previously exposed to an anti-TNF alpha biologic, which previous to COSENTYX, adalimumab was the only FDA-approved biologic. So what did the primary endpoint show at week 16? So looking at the COSENTYX 300 milligram every 4-week arms in the Sunshine and Sunrise trials, we see that 41.3% of patients in the Sunshine trial and 42.5% of patients in the Sunrise trial were able to achieve high score 50 at week 16, meeting primary endpoint. And this is compared to 29 and 26% respectively in the placebo groups. So statistically significant, higher proportion of patients achieving high score 50, the primary endpoint at week 16, if they're on COSENTYX. Let's take a look at what pooled high score looks like when we pull the results across the 2 different studies, Sunshine and Sunrise. So looking at week 16, here we see that COSENTYX Q2, Q4 weeks were at 45.2 and 44.8% of patients achieving high score compared to the placebo arms in those studies with the Q2 and Q4 week dosing, 35.2 and 32.7. So again, higher numbers for COSENTYX. Let's look out to a year now. So at a year, what we're seeing is 59.2% of patients achieving the high score 50 and 61% of patients achieving high score 50 in those patients that were in the original drug study arms. And then also we see improvement of those patients that were in placebo at week 16 and switched over to study drug. What this shows us is that there's durability of response. We see that the curve actually continues to kind of go up. So perhaps continued improvement that we're seeing out to week 52. And durability of response is a really big deal for our patients with HS. If they're having improvement, they want to know that they can continue to expect improvement even after that week 16 mark. So the fact that we have data out to week 52 showing this is really helpful. And then drainage is a really bothersome symptom for patients too. Pain is the #1 symptom for HS, but in terms of, patients and disruption of their daily life, having to wear bandages all the time and the adhesion hurting their skin, not knowing what clothes they can wear, like never wearing anything that's white because they'll get drainage on it. So this is a really big, important point for patients. 83% of patients on COSENTYX in the Q4 week arm formed no new draining tunnels at 1 year. And so, and it was similar for Q2. And I think that that's actually a very important thing that we're able to think about in terms of being able to manage drainage with these agents that we're giving our patients. So we talked about high score 50 and, explained it as, that 50% or more reduction in abscesses and inflammatory nodules, right? So that's all and great, but of course we want more for our patients. If we can get better responses, that would be great. So what about 75, high score 90, even high score 100? So if patients were able to achieve high score 50 at week 16, what we're seeing here is out at 1 year, over 50% of patients were able to achieve high score 75, over a third achieved high score 90, and over 20%, in fact, it averages out to be about 30% of patients were actually at high score 100. And so for those patients that achieved high score 50 at week 16, to be able to tell these patients that are seeing improvement, like out to a year, we're still expecting to see improvement and perhaps even deeper responses, I think is a very helpful thing to be able to say. So we talked about the durability of response. We also talked about that sort of depth of response that we're seeing. And also another thing is that at week 2, we were also seeing a separation of drug versus placebo. So fast results were also seen. I will say that in my clinical experience, I find it much easier to under-promise and over-deliver. So for my patients in my practice, I really like to tell them, please try to take this medication consistently. I'd like to reevaluate you in 3 to 4 months to reassess. That way you give those patients where maybe they're going to have a decent response, it's just taking them a little bit longer to get there, that they stay on the medication and adhere to it and give it a real chance before deciding, how they're doing. So here's a graphical depiction of what a secondary endpoint of AN50 would look like. So AN50 means a 50% or more reduction in abscess and inflammatory nodule count relative to baseline. So it differs from high score because it doesn't talk about the fact that the number of abscesses and number of draining tunnels at baseline need to stay the same. But so the idea is just 50% decrease in inflammatory lesions, abscesses and nodules. So here is what a baseline photo looks like. And then AN50, you can see the benefit there. And so, even with 50, patients notice the difference. Of course, we're always trying to study higher and higher thresholds for success. So in terms of reduction in abscesses and inflammatory nodules at week 16 in the COSENTYX 300 milligram Q4-week arms, Sunshine and Sunrise, we see 51.6% achieving it in the Sunshine trial, 52% achieving it in the Sunrise trial, and this is compared to about an average in the 30s, like 33 and 35% respectively, for placebo in the Sunshine and Sunrise trials. So significantly more for Sunshine and Sunrise COSENTYX patients being able to achieve that AN count reduction. Let's look at the pooled proportion of patients achieving AN50. So this is now patients that are grouped together across the 2 trials. We can see here, again, week 16, we're seeing 56.2, 53.3% of patients in the active study drug arms on COSENTYX versus 39.7 on placebo. And then out at 52 weeks, what are we seeing? So again, the placebo patients have now switched to be on active medication. So about 71% of patients on COSENTYX had improvements in abscesses and inflammatory nodules at 1 year. And you can see how when patients switched from placebo, they also had improvement in their AN count as AN50 ability to achieve it as we would expect. Another important measure for HS patients, we talked about the, just lesion counts itself. We talked about durability of response. We talked about, depth of response with that. We talked about drainage. Now we're going to talk about flare. And flare is a huge component for the HS experience. Patients have a lot of anticipatory anxiety about flares. They could be planning a really big day, whether it's, let's say, graduation is coming or a school dance, or they need to go to work for a big project. And if their HS flares, it just throws everything off. So flare reduction is huge. And that's actually one of the ways I counsel my patients about starting medications is I tell them, I hope this medication is going to decrease the frequency that you have HS flares. And when you get HS flares, I hope they're much less severe and they clear up faster. So that's one way I talk to my patients about what to expect in terms of medication success. So there was reduction in flares in the COSENTYX arms compared to placebo. So looking at week 16, what we see here is that about 75% of patients in the Sunshine and Sunrise trials at week 16 had experienced no flares, flares being defined in the clinical trial setting as a 25% or greater increase in abscess and inflammatory nodule count with a minimum increase of 2 abscesses or inflammatory nodules compared with baseline. So again, most patients, 75%, at week 16 had 0 flares, and this is compared to about 64% of placebo patients across both trials not having flares. So more patients on COSENTYX being able to be flare-free, basically. Very important measure for our patients with HS. And then what happens out at a year? So about 78% of patients on COSENTYX had 0 flares in the Q4 week arm in the Sunrise trial at 1 year. So we do see a maintenance of that ability to try to stay flare-free even out through a year, which is really impressive. In terms of skin pain, so let's talk about pain now. Reduction in skin pain was seen at week 16, and it was observed to continue through 1 year. 70% of patients with moderate to severe skin pain at baseline reported mild or no pain at 1 year. Very important patient reported outcome because our HS patients, they don't want to be in pain all the time, right? So that's really important to be able to counsel them. And then just impact on quality of life. I've spoken about how devastating HS can be on quality of life. So with COSENTYX, patients did report improvement in quality of life. What was used was the DLQI, that's the Dermatology Life Quality Index. It's a quick and easy 10-item questionnaire where patients talk about various domains, like about symptoms, about their ability to function, about their relationships. And basically it's scored from 0 to 30, with 30 being like a devastating effect on quality of life. And in order to have a meaningful difference, a meaningful improvement in quality of life, you need to basically have a 4-point reduction. And so one of the endpoints looked at here is what proportion of patients were actually able to meet a 5-point reduction in DLQI. So clearly a meaningful improvement in their quality of life. So let's take a look. So again, we're looking at pooled responses. So the 2 trials combined together and put into either COSENTYX Q2, Q4 arms, and then up through week 16, the placebo arm before it switches. And what we see here is improvement in superiority of patients who were able to achieve that DLQI improvement if they were on COSENTYX at 47.1 and 42.5 versus placebo at 30. And then out through a year, we're seeing basically like, a sustained ability to maintain that improvement in quality of life, maybe even some improvement. Now about 50% of patients who are on COSENTYX out through a year able to show that difference on the DLQI in terms of improvement in quality of life. So with COSENTYX, patients may experience fast and lasting results. We saw a reduction in the number of inflammatory nodules and abscesses by half with no new increase in draining tunnels. And with COSENTYX at basically going out to week 52 or year 1, 71% of patients had a 50% or more improvement from baseline in abscesses and inflammatory nodule count. 83% had no new draining tunnels. 78% had 0 flares in the Sunrise trial. 70% of patients who started with moderate to severe pain now at no pain to mild pain. And many patients were observed to have that improvement in health-related quality of life that we talked about. Let's talk about safety profile. So an important thing to note right off the bat is there have been several trials done with COSENTYX already, right? And so in terms of the HS clinical trials, an important takeaway point is that there were no new safety signals that were detected. So this is a busy slide. I'll just orient you right now. So we're looking at the COSENTYX safety data at week 16 on this slide. And again, you can see the Sunshine trial data, the Sunrise trial data, and then the various study arms that patients were in, COSENTYX Q4, Q2 weeks, and then also placebo. And what you'll note off the bat, if you just look at safety overview, any adverse events, numbers are very similar across. In general, the numbers were very similar across. So some of the things I'm going to turn your attention to, so with deaths, we see 0 there. fungal infection disorders. So when we think about COSENTYX, we think about IL-17 agents. We're curious about fungal infections and Candida infections. We can see here it's very similar rates actually in those first 16 weeks, you can see. And also most of the Candida infections were mild, mild to moderate and transient, localized, and could be treated through. And basically patients, the majority of patients did not need to discontinue the medication due to their, Candida. And I'll just say too, in our experience as dermatologists, if patients have thrush or they have yeast infections, we know how to treat that. We can use an oral antifungal agent like fluconazole. We can use clotrimazole troches or nystatin swish and spit, but it is helpful just to know about so we can counsel our patients and also let them know there's treatments for it. And then you can see also for things like malignancy, major adverse cardiac events or MACE and new onset IBD, very low numbers throughout. So let's go out to a year. What does the safety profile look like out through a year? So again, no new safety signals here. We can see over basically at the Candida infections, again, I wanted to orient too. So there's now columns, any COSENTYX Q4 weeks, any COSENTYX Q2 weeks, basically combines those patients who started out on Q4, Q2 weeks, and then the placebo flipped into the Q4 week arm, for example. You'd see them in the any COSENTYX Q4 week arm. That's why those two columns combine the numbers that were in the two columns, the columns to the left of them. It's like an inclusive column. And again, numbers are no new safety signals here. You can see low numbers for malignancy, MACE, IBD, and similarly with Candida, still infections, mild to moderate, typically transient, and able to treat through. Very few needed to discontinue. There were, if you see on the sunrise under deaths, there were 2 noted in the any COSENTYX every 4 weeks. One was a patient with aortic stenosis who developed an MI at day like 219 on COSENTYX. And another was a patient who had a history of Crohn's and had duodenal ulcers causing a GI hemorrhage. And that patient also, it was day 219 on COSENTYX, and it was over a month after they got their last COSENTYX injection. So I just wanted to mention that there too. And then IBD is just another thing we think about with COSENTYX and with IL-17 agents. And so what I wanted to say here is that in the Sunny trials, there was less than a 0.3% incidence of new onset IBD cases with COSENTYX, and the prevalence of IBD in the general population versus patients with HS is actually 1.3% in the general population and 3.3% with HS. So I think knowing that context is also helpful for us to consider, remembering also that patients who had a history of IBD that just wasn't active were allowed into this trial. So with COSENTYX, we can trust in a well-studied clinical profile. It has had over 74,000 patients that have been on it. There's no boxed warning. There's no suicidal ideation and behavior warning, so you don't need to counsel about that. And you also don't need to counsel about routine lab monitoring, like you don't have to check LFTs throughout treatment. You do need to check the quant gold prior to initiating treatment. There was also no trend toward increased adverse event incidence rates of IBD, Candida, MACE, or malignancy through year 5. And I just think that that's really helpful that there's data that goes out several years with COSENTYX just because it's been on the market for so long. So we have a lot of data regarding safety on this medication. And just some important safety information, some ISI. So we talked about some of these already, but in terms of infections, COSENTYX may increase the risk of infections. I think if patients have an active clinical infection when they're coming to see you, you should exercise caution the way you would before starting any biologic. Pre-treatment, evaluating for TB is standard of care, so getting like that quant gold. IBD, so exercise caution when prescribing COSENTYX to patients with IBD, and patients treated with COSENTYX should be monitored for signs and symptoms of IBD. There were post-marketing reports of eczematous eruptions, so if patients develop that, you can either treat through or decide what the best clinical course of action is depending on that particular patient. Hypersensitivity reactions have been reported with COSENTYX. One thing of note is that the Uno Ready pen now does not have latex in its cap. So for latex sensitive individuals, that's a very helpful thing to know, because the COSENTYX Senso Ready pen or the pre-filled syringes, they do have caps with natural rubber latex. So Uno Ready is good for your patients that are latex sensitive. Avoiding the use of live vaccines in patients treated with COSENTYX, and just knowing that the most common adverse reactions are nasopharyngitis, diarrhea, upper respiratory tract infection. So getting started on COSENTYX. Starting your appropriate patients with HS on COSENTYX, let's talk about that Uno Ready pen that I had mentioned. So in terms of dosing, it is a 300 milligram once weekly, so for 5 weeks, initial dosing, so you're loading them with once weekly for 5 weeks, and then they stay on COSENTYX 300 milligrams every 4 weeks after that for maintenance. What's great about this is that there's actually flexible dosing. So if you have a patient where every 4 weeks is not quite enough for them and you think they need a little extra help more, you can basically ask for every 2-week dosing, and that's on label. So the fact that it's on label for us to go from 300 every 4 weeks to every 2 weeks means a lot less work for us in terms of, asking for authorizations and appealing with insurance. And then also one benefit of being able to start out with that every 4 weeks in my practice that I found is, sometimes it's hard for patients to switch from taking oral medicines to taking an injection. And so I'll tell my patients, like right now, you might be on several different medications, and we really want to pick an agent that can help decrease that over-inflammation that you have. What we can do is start an injection where you don't see the needle. It comes as a pen, so you don't see the needle. It would just be once a month. And then you start first with some loading doses to get your medication level up to where we need it to be. But after that, it's just monthly. And I feel like saying it like that also can be helpful for patients who are thinking about this like they might be thinking about insulin, where people inject themselves all the time with such frequency. So here's the Uno Ready pen, a photo of it. It's one sub-Q auto injector. Cap is not made with latex, as we discussed. It's convenient and positive self-administration experience, where there was a study done where 98% of patients with moderate to severe psoriasis reported no pain at the injection site. COSENTYX is also covered as a first or second line biologic in HS across private insurance, Medicaid, and Medicare. And there are access programs to really help your patients start and stay on COSENTYX. And so that's really helpful. There's a website, readysetcosentyx.com, that has a ton of resources for patients and also just for providers in terms of helping patients, start on forms, a start tool, a start form, and then also for patients, there's injection resources. So it's very helpful in terms of helping our patients access this medication. All right, so in conclusion, we can help patients find HS symptom relief with COSENTYX. Fast results were seen as early as week 2, lasting relief at week 16 with reduction in numbers of inflammatory nodules and abscesses. We saw the primary endpoint, more patients reaching that at week 16 than placebo. Trust in a well-studied clinical profile, and COSENTYX is covered on private insurance, Medicaid, and Medicare, so access is good. All right, I'm happy to take questions. Thank you so much for spending some time with me today, and excited to answer anything you guys have.
Jennifer, thank you so much. And this was an eye-opening lecture. Not only we learned a lot about HS, but also about COSENTYX. So if anybody has any questions, please submit your questions on the question pane on the right-hand side of your screen. Meanwhile, we do have a couple of questions, if I may. So one is, you really did a nice job, but did not elaborate. You touched upon it, the relationship of the early 1, early 2 stages versus the number of the lesions versus the moderate to severe. If you can elaborate a little bit on that, it will be very helpful.
Yeah, this is a very interesting point, because we use Hurley staging a lot to sort of, in a quick way, try to decide how severe a patient's disease is. And so just for the audience, Hurley 1 is patients have abscesses and nodules, but they don't have scarring or sinus tracts, right? Hurley stage 2, They may have scars and sinus tracts. There's signs of tissue destruction, but there's still normal skin separating out the lesions. And Hurley 3 is just like an entire anatomic area is covered with the HS lesions. Some limitations of Hurley staging is it really was meant originally as a sort of surgical staging system. And so you can think about a patient where, for example, they have multiple inflammatory nodules and abscesses, and it's on many anatomic regions, but they just don't have a scar sinus tract. For me, that patient absolutely could be deemed a moderate to severe patient. But if we're only thinking about it in terms of Hurley 1, 2, or 3, they are Hurley 1. So that's why I think that it's not a perfect system by any means. And for me, it's not the way that I would classify whether or not somebody is actually biologic ready. And we don't want to miss the boat and start a biologic late because we're waiting for signs of tissue damage when we're seeing a patient who's suffering with just recalcitrant abscesses and nodules.
That's very helpful. And, it's a sort of a new disease. It's not a new disease entity, but it's a new disease entity that's being studied, right? So it's really helpful for us to understand the staging and the classification and the inclusion-exclusion criteria when it comes to all those studies. Speaking of the studies, another issue that you mentioned quite a bit, the patient-reported outcomes, right? Usually we don't see this many patient-reported outcomes in clinical studies, and now this is becoming important, especially in cases in disease states such as HS, where patients are really, really miserable. Can you elaborate on that a little bit as well?
Yeah, I think, the reason these are so important is because when we think about even just a score like HiSCR, the primary endpoint, for example, right? Someone's lesions going down by 50%, even just the primary endpoint, it doesn't tell us about the patient's pain level. It doesn't tell us about the patient's quality of life. I feel like with HS in particular too, I've definitely had patients where sometimes you may not be seeing all of the disease activity. So things may be looking better, but there's still inflammation there that's causing still intense pain. And so unless you ask, you're not going to know. And that's why I think when we see these patients in clinic, it's really important to ask these questions like, how is your pain doing? Even if you wanted to get more, objectively, like on a scale of 0 to 10, how would you rate your pain over the last 24 hours? Just so you can kind of track and make sure that they're actually feeling better, in addition to you as a clinician seeing improvement in the lesions.
And this will be very helpful in the future when it comes for reimbursement issues, right? If we can document those patient-reported outcomes, it's always helpful. I have a question on the chat box here. What are the 3 top side effects, I guess he's meaning adverse events, of COSENTYX in this particular study?
That's a good question. I believe it was headache and nasopharyngitis, and also worsening of HS.
HS. That's interesting, right? And at this in my practice, I see quite a bit of different population when it comes to HS versus psoriasis. I don't know if it's the same in your case, or maybe you can elaborate a little bit on the population. Who do we see mostly as HS patients?
Yeah, so, HS really can affect anyone, but at least in the US, it appears to disproportionately affect women. More prevalent in people in their 20s and 30s, but there absolutely are cases, pediatric cases, and a lot of patients actually will experience symptoms between the ages of like before they're 21. Also, it disproportionately affects African American patients, as compared to white patients. And I say this though because with caution, because I feel like the studies on prevalence also have mostly been based off of claims databases, and we know that HS is underdiagnosed. And so we don't know how many men are walking around undiagnosed with HS and just not seeking care for it. So I feel like this is what we know for now, but as hopefully awareness spreads and education spreads about HS, we'll be able to do more rigorous prevalence studies to get a good idea. And either way, if somebody has a patient in their office and they're noticing basically a history of recurrence of abscesses or boils or nodules in any of these areas, regardless of that patient's demographics, HS should be like top on differential.
So do you think I somehow, now that we have one more treatment option, I started seeing more HS patients as if they're coming more and more to the clinics. Do you see more increase?
I am definitely seeing more patients self-refer to my clinic, and I think part of that is the public awareness campaign that's going on, and that happens with the advent of new medications. And so that's why I think it's so important that we have these pipeline medications for HS, that we have this new indication, is because we know that this increases awareness, and patients will hopefully be able to advocate for themselves and say like, okay, I need to see a dermatologist, and they'll show up at our door. Whereas before, especially if they've had some negative interactions with the healthcare system, for example, they went to the ER urgent care, they were told that it's because they didn't clean themselves well enough, or there's nothing further that can be done. They may be hiding in the shadows and not, coming out for treatment because they don't think there's anything that can be done. But hopefully now, more medications, better medications, we can really help ease the suffering for a lot of these patients.
Well, thank you so much. We are able to answer all our questions, and we'll give our audience a little bit more time. So thank you so much, Jennifer, for joining us. And I'd like to thank our supporter, Novartis, tonight. Thank you for making it possible. So now that we're done with our Novartis program, I'd like to invite you to our next webinar with Dr. Jerry Shapiro, and he's going to be discussing what's possible with Olumiant 3-year data for the first FDA-approved systemic therapy for adults with severe alopecia areata. I thank you so much and have a good evening.
Good night, everybody.